Okay, so as Masood so kindly introduced me, I'm Director of Dementia's Platform UK, MRC-funded public-private partnership. And everything I'm going to say today really is a result of the close working between the academic third sector and industry partners. So I'm extremely grateful to them. Here they are. This is not a token slide at the end of a presentation. These are real partners. They shape the program, that they contribute massively with their knowledge and understanding and enthusiasm to what we do. So I've been asked to talk about trial-ready populations, and we've already heard from Martin about what you might describe as the epidemiologic approach, where you have very large population-based recruitment. Because you're population-based, your numbers aren't particularly constrained. You keep it simple, minimal inclusion criteria. You don't really require detailed mechanistic understanding to demonstrate efficacy, and it's very good for testing treatments and therapies. Okay, what I'm going to focus on, and I think Martin did an absolutely excellent job, and I have a lot of time, what you might describe as the protest model. I think it has an enormous amount to offer. But historically, we've been more focused on what you might describe as mechanistic approaches to recruitment. They tend to be register-based, where the members are consented for recontact. The numbers tend to be constrained by the level of characterization that enables you to risk stratify people more precisely. They're most useful for mechanism specific hypotheses, and therefore they're very good for experimental medicine. If you were to look at the dementia publications over the last 50 years or so, they've increased exponentially. Now, if you then subdivide that using the right-hand Y scale by trials, cohorts, and registers, the interest in registers is relatively recent. I think they've been going on, 15, 20 years at most. And then again, most of these registers are very locally based, if you like, university-based, health center-based, and full of all the vulnerabilities of being underfunded, under-resourced, and focused on the interest of the PI at a particular point in time. And if you then look more deeply into those, you come up with a few, and not a large number, a relatively few, what you might describe as national or regional registries with a national or regional reach. And I think the numbers are quite interesting here because effectively, though you have some very young registers like the Scottish Brain Health Register, it's very small because it's just getting going. You have an inverse relationship between complexity or level of precision and size. And that directly relates to the cost and the challenge. And the big decision is, if you're constructing a register, is what level of complexity or what level of precision, what level of risk stratification are you going for? And it's a very, very big compromise. So if you look at Barcelona, the beta alpha and the EPAD registers, they are blue ribbon registers. They're fantastic. They measure everything, imaging, genotyping, blood biomarkers, but they're small. They have between 2,000 or 3,000 individuals. And they're very, very expensive. Millions of pounds have gone into each of these registers over the years. Then you go down to the DPUK registers, much larger, but no imaging. And perhaps imaging is something that you particularly require. Then you could go down to the big American registries, genotyping, no, but serial cognition, yes. And it really is a challenge as to know where to pitch your register. So I just want to talk a little bit about the lessons learned from DPUK and how we've pitched things. We run a high trust pre-competitive environment. We have close involvement with our partners, and we run integrated data management across our work streams. So Here we have effectively the first of our 3 work streams. This is the data portal. Many of you will be familiar with it. And we've had over 1,000 access requests over the last few years. We have nearly 1,000 users. We manage on behalf of the principal investigators data from 50 cohorts. Decision time for access is 23 days and data provision time is 1 to 2 days. We also run a trials delivery framework. This is led by Vanessa Raymont, who is on the call. We have 2 trials registers. I'll talk about those later. And we're working to deliver trials more efficiently around the UK. Now we have an experimental medicine incubator, which looks at 3 themes. We discovered that trying to bring all of these together is a very, very difficult enterprise because of reasons which I will go into shortly. And what this really is a story of how we've addressed that, hoping that everybody can learn a few lessons from that. Our approach is not the classic process-driven approach. Here we have the classic translational pipeline. We do this, you do that, you do the other, and you end up with effectiveness monitoring. We found that uninformative, if I'm honest with you. It really didn't help us understand what we were trying to achieve. So we went back to what we would describe as a more purpose-driven approach, where we looked at how can we achieve end-to-end data management? How can we enroll by phenotype according to genotype? How can we conduct multi-centered, mechanism-targeted experimental studies? And where we would really like to go, but it's beyond the remit, and I only mention it because I think it is a critical gap in the UK infrastructure, the global infrastructure, is how can we move towards what I would describe as a disease progression cohort. We are looking at the trajectory of individuals from the earliest risk through to diagnosis, treatment, and ultimately their demise. We cannot do that, although that would be a fantastic discussion to have. I'm going to focus on the first 3. The big problems we came up with were not this little issue with this area and this little issue with that institution. They were effectively structural challenges. And these structural challenges affected everything. So I'm going to focus on those for a moment. The 3 structural challenges we came up were collaboration. Everybody wants to collaborate. Nobody wants to pay the price. And that makes life very difficult. A second structural challenge was data access. And how do you clarify the property rights so that who knows who, for what reasons and why, people could give access to data? And what about trustworthiness? It is a big deal of the Dementias platform is generating and maintaining trust, because that just makes life so much easier. And I think one of my jobs as director is just to go and have coffee with people. It's simple, really, just to make sure I understand where they're coming from, and I understand and they understand that they're playing the game, and that actually this platform will work because it's based on good relationships which are enforced by the design structures. So I'm going to look at each of those 3 first. Okay, we love collaboration. Trouble is, collaboration, which I would define equitably as the exchange of benefits, not the giving of benefits from one party to another, but the exchange of benefits, it costs. And the costs rise exponentially with the complexity of the collaboration. So what we would really like to do is to reduce the transaction costs. So as the transaction costs get larger, so the net benefits peak and then get smaller. And you get to the place where, frankly, beyond this limit, you do not want to collaborate. It is too hard. This guy is a pain in the neck. I cannot deal with these contracts people. Do they really know what they're doing? How can I find somebody who does? And all of those questions come up. And at the end of the day, you think, well, I need some help, but it's just too much trouble. Okay. What can you do about it? Well, it's really simple. You reduce the costs. And as you reduce the costs and increase the benefits, so the line at which you stop collaborating gets pushed further and further and further to the right. So if you wanted, in a very simple way, to increase collaboration, increase impact, the simplest thing you could do is just to reduce the costs. And you can do that by standardizing, streamlining your procedures, and we will come on to those, a few of those. Let's look at accessing the data market. Now, academics don't really like to think of data as a data market, but it really is. It may be less formal than some markets, but it absolutely is a market of who gets access to what for what reason. And in some of these categories, this is a very standard economic understanding of goods. In some of these categories, there's no dispute. For example, a privately funded resource is a private good, and no one would dispute that. Scientific knowledge is a public good. You can't control access to scientific knowledge. It's the last thing we would want to do. So we stick everything up on PubMed and preprint, et cetera, et cetera, et cetera. We want everybody to have this. But there are some gray areas. What about biosamples? Biosamples, well, they're actually very valuable. They're depletable. You want the people who can best use them to have access to them. So you might want to have some sort of screening procedure for guiding access to that, just in the common good. But what about digital data? Well, it's not depletable. It can go on forever. You can have millions of copies if you like. So how do we provide access to this, what you might describe as a club good? Now, when you come to academic data, academic samples, the property rights are really unclear. And what that leads to is people not really knowing what is the best use of the resource. I'll give you just one example. UK Biobank. Whether you like or do not like the property rights, they are crystal clear. Everybody knows exactly where they stand, and therefore they use it. They know how to get access. The process is very straightforward. It is the same for everyone. It is equitable. And that's what people look forward to. If you go to any company, they would like to know, okay, just give me clarity, give me certainty. Therefore, I can work within that. A further, if you like, ambiguity comes in public-private partnerships. What are the property rights in a public-private partnership? Now, I'm not saying there are easy answers. I don't think there are. I think it's a social preference. It's something we have to discuss, but it's something we have to discuss so that we understand clearly what they are. And I would argue that a principle for assigning property rights is really they go to those in the best position to use the resource for an agreed, desired outcome. And that doesn't necessarily mean those who generated the data. It doesn't necessarily mean those who were using the data first. It means how do we allocate these rights, these access rights for the public benefit? So we need to clarify property rights. We actually also need to have what I would describe as trust by design solutions. You know, many collaborations, and I think the vast majority of collaborations represented here today are really based on what I might describe as informal, in brackets, bespoke, trust-based solutions. And they're great. They really are great. For bilateral agreements, they're efficient, they're quick, they work, no problem at all. However, for multilateral agreements, they're really inefficient because everybody has their own caveat and their own condition. And I think the longest contractual arrangement I've been in so far in terms of trying to negotiate multilateral agreements between independent sets of lawyers is about 2 years. I mean, that is just ridiculous, but it's not uncommon. It really is not uncommon. So how do we get around that? Well, it's actually quite simple. We have what we might describe as trust by design standardized agreements, okay? Efficient multilaterally, they standardize your legal agreements, they standardize your data models, they standardize your processing pipelines, they standardize your audit trails. They're transparent and everybody knows what they're signing up to. In the Dimensions platform, we do this with our data deposit agreements, and we find that people might kick up a fuss and huff and puff for a bit, but actually they get used to it. It's not a big deal. And once they do sign it, then the data, the whole process flows very, very comfortably. So we've managed it with the data, with our data management. Here is our data application, our data reporting process. This goes through to MRC, automatically on a monthly basis. Everybody knows what's going on. Everybody understands. And we have, as I look at a large number of users across the world, we're a bit short in Africa. We need to work on that, and we'll be doing that within the next 12 months. But basically, we have a trust by design environment. And this is supported by our technology networks. We have imaging, IPSCs, and informatics networks. And the idea here is that through these standard pipelines, we can bring raw data into processed data into a virtual environment. And whoever has access to that can have access to standard data sets with markers, DOIs, which are persistent and therefore rapidly, easily replicable. For targeted experimental medicine, this has been more difficult. Okay, so the data portal, that's worked neatly, frankly. I think it's one of the best data portals you will find. Although we've done a large number, as you see, 90 studies across 9 centers, and many of these are still being conducted. We have them in 3 areas. So we have different areas, we have different locations, we have common major challenges. And that boils down in the UK to contracts, radiochemistry, and risk stratified enrollment. And these things really have slowed us down. And but we're working on them. Because of this, we've had to start our own research registers, which I described earlier. We have 2 research registers, the Clinical Studies Register, which is an opt-out register, and the Great Minds Register, which is an opt-in register. I can go through the details of why we have the 2 consents later. But these registers do allow us to stratify and to recontact. The Great Minds Register is the one that we have most control over. So I'm going to talk about that. We are still working out how best to make these operate. We are running 5 studies, you'll see at the bottom there, as loss leaders. So we're using these studies essentially to help us work out efficient, rapid recruitment systems. Part of the register problem, if you like, the enrollment problem, is actually knowing who you want to contact. So for Great Minds, we have this, if you like, this dashboard where you can say, okay, I would like to look at people who don't have dementia, people who have no mood problems, people who have a relatively low cognitive performance score in this age group living in this locality. And then I'm not going to give you a live demonstration. That is a real hostage to fortune, okay? That would tax my technical abilities to the absolute limit. But trust me, it does work live. And if you're registered on DPUK, you can go and play with this to your heart's content. But you might like to select according to geographical location. I need people within 40 kilometers of Cardiff. Well, out of that register, we would have 1,260 who would live within 40 kilometers of Cardiff. You might want to select according to health status, whether that be blood pressure, diabetes, history of stroke, and methyl present in the body. Of course, these indicators are selected, they're optimized for dementia researchers. Or you might like to select according to cognitive performance. And here we have the distribution of peer associate learning tests from the CAN tab. You might like to select according to the preference of a study. Some people will not want to be going to a PET machine or into an MRI scanner. And it's helpful to know that beforehand. Some would not like to be involved in a trial, a clinical trial. They'd rather be involved in another sort of study. And again, it's helpful for us to be able to tell that in advance so that you can then go to target the people that you really think are likely to accept the invitation. So having worked through how we can do preclinical recruitment, the next challenge really was, how can we do clinical recruitment, and how can we get the studies, if you like, working efficiently with reduced transaction costs around the country. And here, Vanessa Raymont has been very active, and she's working on accrediting research active memory clinics, which have streamlined and standardized SOPs. And I think the core here, what I would describe as the 4 C's. You really want to have streamlined and standard consent, costing models, contracts, and core data elements. I think that, to my mind, if we could establish that across sites in the UK, I think we would be changing the, I mean, we use the word transform in a rather sort of throwaway fashion, but it would make an extraordinary impact if we could achieve that. And through Vanessa's good offices, we are working on that. We have 13 sites signed up, with another 4 invitations pending. And the idea is to discuss with these sites as equal partners how to achieve what I would describe as the 4 C's. So, lessons learned for trials-ready populations. Number 1, reduce transaction costs. It is so simple. My suggestion is, and again, it's horses for courses, that you characterize cheaply and at scale. For DPUK, this means a questionnaire, cognitive performance, blood, but not CSF or imaging. We thought that this would not be cost effective. Clinically, CSF is hard to achieve. You need to be on site with a clinician. Imaging, not everybody wants to be imaged, and it requires going again to a specialist center. And many studies, even if you did screen for some sort of structural molecular criterion, they probably just do it themselves again. And obviously that would be at the need of the study. So we thought, no, we won't do that. What we do need is the background leading cognition, preferably serocognition. We need to get some blood for genotyping and emergent biomarkers. So that would be our criterion for characterization. And then we would streamline and standardize. And just as we've done that for data management, so we would do it for experimental medicine. The next thing that we would have learned is that you do need to maximize data access. What is the value proposition? Many people approach the basic scientific value proposition as data. And I think in one sense, yes, there are data acquisition costs and data transfer costs, but the real value lies in the tools, not the data. The impact lies in the tools. The data are the means to the end. And sometimes we've had to spend a bit of time talking with prospective academic and industry partners about this issue. Because in order to achieve the tooling, which makes the difference, you need to make access to the data as cheap as chips. And that doesn't always go down well with all the people I've spoken to. And again, you need to clarify the property rights. What is the potential benefit here? The risk is that we hang on to our data, giving access to it. It's like it's a big oil field under the sand, and one day it's going to be valuable, but you never know. Wind power, wave power might just come along, and it's not as valuable as you thought. So why not work out how to get some immediate benefit from these assets for everyone? And then use an opt-in consent rather than opt-out consent. It definitely gives you much greater control and much reduced transaction cost. In great minds, we can easily do studies because we are the points of contact. We are the sole point of consent acknowledgement. In the opt-out registers, those consents lie with cohorts. And as soon as that happens, even though the cohorts may be very willing, you have a delay. You have another layer of bureaucracy. So I would work transaction costs in for opt-in. And I think finally, you'd want to build trust. In DPUK, we go to a fair amount of effort to align our goals. Our studies with industry partners are very much co-designed. We know we are honest about what we want out of this, about what we think is going to work, what we think isn't working. And we do this in a high trust, pre-competitive environment. And what this means is people share ideas. People are willing to share technologies. People are willing to invest more when they see that something doesn't work. And we're all willing to admit it when they invest more when something does work. And we're all willing to admit it when something doesn't work. And then we have the trust by design data management. This is so straightforward once it's up and running. It just makes life so much easier. Then I suppose I have just one final thought, and that is persevere. You know, these things are like fine wines. They get better over time, but don't persevere passively. Change divided by leverage equals time. All right. So one of the things we found at DPUK is we've got some really good solutions, but really compared to the bigger ecosystem, the bigger problem, we're quite a little minnow. You know, we have modest funding, we have modest leverage, but basically the solutions we implement are completely transferable. So we're going to persevere. And I hope that over the next few years, you will all see the benefit of that. Thank you very much.
Thanks so much, John. Yeah, you've given us a real insight into the problems because, you know, I guess the key question is how difficult it is, really, how difficult it is to recruit people into clinical trials, anywhere, not just in the UK, in this particular space. So let's just open up the questions here from people and see. We've got one here from John Davis. How is the UK dementia trials ecosystem learning from the pandemic and efforts like recovery, John?
I think it showed us what can happen. You know, where there's some political will, and I don't just mean with a capital P, where you have investigators, where you have industry wanting to find a solution rapidly, where they see it in the interest of everyone to find that solution rapidly, then things happen. Yes. It was fantastic, and I think that to have a similar dementia task force is a very, very shrewd idea. I think AIUK and others are pushing for that, and I completely support it.
I mean, one of the issues you touched upon is this sort of contracts and regulations, and universities are as much to blame as anyone else, right? So if there was a way in which there was a standard format for this, that would potentially just improve things from your point of view, or not? Because
it would transform things, and yeah. I think there is a way. Yeah. I honestly think it's just a matter of leverage, and we're not talking egos here. You know, we're talking. For example, let's just say hypothetically that there was a neurodegeneration initiative coming along. You never know, it might. The issue there is, how do you start? Would that have the leverage to say, okay, this is the contractual form we use. These are the agreements we have. If you want to play, these are the agreements we use. I think that simple act would be completely transformative. And because you don't have to play, no one's being forced to play. You're just giving people the opportunity, but the opportunity on these terms. Right.
Yeah. And even the big universities would want to play. So yeah. They'd have to agree, wouldn't they? I mean, I think this is a real problem because everyone starts inventing the wheel for themselves when they're faced with these things. So that really is a bureaucratic area that we should think about. An important change focus, right? That would be amazing. Fantastic talk, John, says Cornelia. Have we used patient and public involvement enough in dementia?
Well, I think that's a really hard question to answer, because not being omniscient, I'd have to have a guess. And the guess would be no, but that's not just a simple politically correct statement. What I would want to know is in what areas is the patient-public involvement contributing to benefit? Okay, so it certainly contributes to benefit in terms of understanding people's willingness to participate in studies and the public concern that we do find solutions. I think it contributes massively in terms of prioritizing what issues are important to the public and therefore what should be prioritized in terms of the research agenda. So I'm really fully behind that. When it comes to this evaluation of evidence, of mechanisms, etc., I'm not sure that it's so helpful, if I'm honest with you. So as long as we're clear about where it works, where it contributes, and where it doesn't, then I think we should do more of it.
I guess there are two areas here, aren't there? There's one about recruitment into something like Great Minds. How could you increase recruitment? But there's also the public's leverage and pressure. I mean, I think we've seen that amazingly in motor neuron disease and ALS in the last year. The amount of pressure put on the government by people who have relatives or people who are patients themselves has made a huge difference. They've put £200 million on the table for research all of a sudden because the public pushed them into that space. So I think Cornelia's question is probably maybe twofold. One is, could we not recruit more people into, say, DPUK if we had an advertising campaign? And the second question is really about trying to get the public on our side to push the government. What do you think about those two?
I think we really could. I think DPUK has been constrained by the ecosystem, but we were finding ways around that. Initially we were unable to recruit publicly by advertising, but we are now, but we had to work on that. I think public pressure on the government to spend money is absolutely critical. And the more that we can work with the Alzheimer's Society, AIUK, and also via the MRC, I find the MRC, do listen very closely to public comment as well as scientific comment, the more we will be able to get benefit from the government.
And maybe we just don't use this route enough, that we're a bit too closed in terms of trying to get leverage through scientific or pharmaceutical company routes rather than just going to the public.
Yeah, I think so. But again, the people who are good at this are the charities, and I think it's a matter of a holy alliance, to really push collectively. I would, completely recommend that we engage with them more.
Yeah. Okay. And Paul White says, would you like to comment on the challenges and solutions when it comes to recruiting for early stage or non-symptomatic patients? So people who don't even have a diagnosis.
No. Yeah, we've done this through Great Minds effectively, and I think Great Minds is really just a natural experiment as to what you could do. You take broad numbers. We only have 7,000, but let's just think orders of magnitude more. You take very broad numbers, you characterize them relatively cheaply. You then get, by dint of numbers, a distribution of risk, and then you can stratify for particular studies on that basis. So technically it's not difficult, but it is a matter of the strategy is one of size rather than careful selection. So you put your money into casting the net wide and characterizing them cost effectively.
Okay. Other questions for John? While we're waiting here, John, I mean, one of the issues you touched upon was that although DPUK is a flagship program, it depends on funding from both government and other institutions. So, and the other thing you kept on mentioning is trust. So is this a viable model for the long term, that you can, make people believe in this and think that there's something beneficial going to come out of it?
That's it. Oh, Masood, what a good question. So it's the let me give you the example of trust. You know, MRC get from us automatically an update every month. They don't have to ask for it, right? They can query it. They can ask for the form, but they get it. Okay. They know that the project's running good, well, or badly. Therefore, hey, it's straightforward. I think our industry partners as well, one or two are on the line, so I'm going to be careful what I say. Again, the discussions they have actually play out into what happens, you know, in the lab or in the field. So it's something that you earn, and it's quickly lost. It's quickly lost.
Okay, got a question here from Caroline Cake. Thank you, John, really interesting. How important is data linkage of primary and secondary care data for dementia trials ready populations? And how are you overcoming obstacles with this?
It is critically important. How are we overcoming
the obstacles?
Well, yeah. I think we are really constrained by the current environment. It is very, very difficult. So the linkage has been radically improved through COVID, and we are using those mechanisms. But the problem is, as COVID recedes, so those mechanisms are now questioned by those who defend our data access. So the issue then is we mustn't lose this change of heart, this change of mind, this flexibility of thinking. Looking ahead, the UK is in a fantastic position to have an integrated data environment, but it has to be a constrained one, because otherwise you cannot manage the data standards. So for example, if you had a center which was really focusing and efficient on linkage, a center focusing on research data, they would then be interoperable, and you would have two sets of specialists being very efficient in the mutual access of the data. On the other hand, if you have every university in the world trying to do this, or every university in the UK, you've made no improvement whatsoever. You again end up with many agreements, different data standards, everything being underfunded. So let's really take this as a very important strategic moment. We need to have a constrained data environment where you have standard agreements. People are good at what they're good at. They're not trying to be good at everything. And therefore, we are able to operate efficiently.
And what do you think about NHS Digital and what it could offer to something like DPUK?
So NHS Digital could transform the value of our data. There's no question about it. Absolutely transform it. It would be of the scientific value globally would increase by an order of magnitude. The question is, will they? And I don't know. You know, I think that the regulators, as Martin Landry so politically correctly put it earlier, need to have their priorities changed. I really do. It's not a matter of what would be the last possible reason we have for not letting you access the data. It is much more a case of how can we promote public benefit.
Yeah, I mean, this is the extreme end of Caroline's question, isn't it? If you had data linkage into the NHS system, that would be amazing. And a very general question here from David Thomas. He says, how much of DPUK's approach is specific to dementia? How much could be replicated in other disease states areas? Okay, so DPUK solutions are intended to be generic. Okay, so some things are optimized for dementia, like the feasibility tool, because we're funded to do dementia experimental medicine. But the data access, the general principles are all generic, because we're all learning. I'm not pretending DPUK has got all the solutions. We are all learning, and those lessons should be available and relevant to everyone. Yeah, I think you made that very clear, John. Any more questions for John? Your last chance here. If not, I think we need to thank you, John, for being very frank with us and dealing with frankly with the questions we've asked you.